So I want to talk about making health addictive, which may sound audacious or at the very least counterintuitive, but if you bear with me for a minute, I can bring it into focus for you. It really all starts actually one day when I was driving home, as it turns out, listening to public radio, and I heard a story about this phenomenon. People check their smartphones about 150 times a day. That's pretty well known now, 100 times a day, 150. That's an amazing number. Probably that alone qualifies it for addiction, but people have done studies on this with functional MRI and very sophisticated technologies and shown that the same response that addicts get when they have a craving, people get when they don't look at their phones for a long time. This is real. And that's fine, but what really struck me when I was listening to this story, it helped me explain a phenomenon that we had been seeing, which is quite the opposite, and that's illustrated here. This comes from a program we run called Blood Pressure Connect. We have these home monitoring programs, and in this case, your doctor looks you in the eye and says, I think this program of home monitoring for your blood pressure would really help us take better care of your high blood pressure for a number of reasons, and any of them could apply. We give them the technology in the doctor's office and they bring it home, and it essentially involves a cuff and then a hub technology to get the data out of the cuff and move it to the cloud so we can use it to improve their care. And what you see pictured here are two examples of that hub technology that we happen to have in the field at one point when we were experimenting with these various hubs. Now, the one on the left requires you to push a button to upload your blood pressure. The one on the right is passive. It just happens. So we looked at the data from, these were out in the field at the same time, and we just looked at the data, real-world evaluation, and lo and behold, the people that had to push a button were uploading 3 times less often than the people who had passive upload. So while you check your smartphone 150 times a day, I can't get you to push a button once a day to do something that your doctor said would improve your health. This got me to thinking, what's wrong with this picture? And I believe it's all about the psychology that we use, that we invoke when we message our patients about chronic illness. So that's what we're going to talk about. Now, mobile has really been a game changer in health and will be. We're just scratching the surface of how this amazing technology will change healthcare delivery. It's always on, always connected, allows for in-the-moment messaging. Those two alone are game-changing. Think about it. When you're used to traveling somewhere and visiting someone and getting your health care in this dose called a visit, and I can now reach into your life in a contextual way and message you, pretty interesting, that alone. And then there's all that you can collect from the device about your health, the accelerometer data, the GPS data, the Bluetooth connectivity to these sensors, and of course, the phone camera itself to take various pictures of things. All very interesting as a data capture device and, of course, a display device. Now, people are working on all these. There's a lot of innovation, research, companies forming, lots and lots of activity. Not much going on for this last one, and I think this is the sleeper. This is the killer app. These things are addictive. And what I wanted to do was to think about how we could get our messages into the path of all that checking of those smartphones. You know, smartphone addiction leads to scenarios like this. You've all seen or experienced, and then there's a whole culture now around this of different devices to get people to put their phone down and actually talk to you in a bar. It's fascinating. And I don't have any value judgment on that. We're not going to talk today about whether that's a good or bad thing. It is a fact, as I said earlier, that they're addictive. But what we really want to talk about is how can we use that addictive capability to improve health? And let's face it, we need to do something different. Our go-to strategy, not most of the time now when we talk to patients, is we use fear pretty much. That's our go-to motivator. If you don't lose 10 pounds, you'll get a heart attack or you'll have a stroke. That doesn't work. It's obviously not working, right? We have a couple of other tricky things. Another thing we do is we confuse education with inspiration. Just because I can tell you all 9 or 10 things that will be wrong if you don't change your behavior, that doesn't mean you'll be inspired to change your behavior. So let's take a journey now. I think it's about messaging. I think it's about message design. That's my hypothesis. I'm going to share with you 3 strategies and 3 tactics that I came up with that we could use in this mobile environment to create addiction to health. And in many cases, I'll use examples of work going on at our center. I have some other examples to share with you as well. Strategy 1 is make it about life. This played out earlier this morning when John and Jeff Clapp were talking about his daughter, and you know, it's about the daughter, it's not about him. That's making it about life. We don't do very well with that. We just go, again, with the standard stuff. We tell you what's going to happen to you if you don't do something healthy. Why don't we just ask you, what's your motivation? Maybe your kid's wedding is coming up and you want to fit into a tuxedo that you wore when you were 22 years old, or a new outfit. Maybe that's a reason to lose a few pounds. We have to be better about this. Now, our example from the center is text messaging for prenatal care. And this has been very powerful. If you think about it, if I know your due date, I can predict many things about you for the next several months and even for a couple of months postpartum. And you can design a text messaging campaign around that. Each one of these messages came from the OB team. That's what it said. This is your OB team. Oh, things like, it's time to shop for your car seat now, or count your baby's kicks, time for your next appointment, don't forget your ultrasound. All of this in the context of what's meaningful to a woman who's carrying a child. And you can see the stats here, 74% felt better involved in their care. Very, very successful program. Very successful program, all because it was focused on the life part and not a disease part. So make it about life. Strategy number 2, this is another example of make it about life, which I rather like, and that is the simple way we've changed cardiac risk ratio to heart age. You probably all know about this, but my risk ratio of 4.37 doesn't mean nearly as much to me as if you say, you're 55 and your heart is 70 years old. That really resonates with people, and it's the same information talked about in a different way. Make it about life. Strategy number 2 is personalization. This one excites me particularly. The billboard ad and the print ad are going the way of the 8-track tape for a reason, because the advertising industry has figured out how to personalize everything and feed it to us in very, very personal way. We can do that in healthcare too and be very successful. Now, here's an example. This is an example from our group again. The idea here was for type 2 diabetes to improve walking behavior. And what we did was we captured 4 variables. One was, how motivated are you to walk more? The second one was pedometer data. We gave everyone a smart pedometer that gave us continuous activity monitoring throughout the trial. The third was location data, where your home is, where your doctor's office is. The fourth, which isn't mentioned here but turned out to be really important, was weather. Because if you triangulate weather with your activity level, you can predict things about people. That makes them feel really special. We put all that into an analytic engine. It turns out twice a day, automated, so no person involved, motivational text messages for 6 months. The results, you can see in the orange bar that the people in the intervention group had a 0.62 gram % drop in hemoglobin A1C. That's better than the average therapeutic that we give type 2 diabetes. So connected health, better than a therapeutic. And if they were really engaged, which is the middle bar, 1 gram% drop. Both of those astounding results. No human intervention, all driven by personalized messaging. There's a lot of opportunity here. Number 3 is really perhaps intuitive. Social networks, social interactions in the digital age are incredibly powerful for many, many reasons. The example we have of this, and there are many, the example we have is a Facebook group that we created for teenagers with asthma. And we were simply asking the question, if we put them in a Facebook group, private Facebook group, walled off from the rest of Facebook, but they could see each other, would that act as a therapeutic? Would that change their outcomes as asthmatics? These are those results. So 79% engagement with a tool that we use to measure engagement called the ACT, and baseline is 20% engagement, so engagement went way up just because we put it in the Facebook group where they were. We just put the survey tool there and they all filled it out. Very simple. You can see the final scores went up by 4 points. The average increase, and in this case, increase is a good thing. It's not like A1C where it's decrease you're looking at. Increase of 1.47, again, better than a therapeutic. Most new inhalers give you about a 0.5 point increase. All because we just threw them in a social network. Social's very powerful. We can do a lot with that. Now, strategy isn't much use without tactic. So I'm going to share 3 tactics as well. The first one is subliminal messaging or subconscious triggers. Some people get negatively turned off by the term subliminal messaging. If you have time, I really urge you to go to the American Legacy Foundation website and look at some of the wonderful things they've done with the Truth Campaign. If you have teenagers, you might have heard of the Truth Campaign. If you don't, you probably haven't. But to sort of boil it down because of time constraints, it's advertising with all of the modern techniques, viral ads, Twitter, etc. It's advertising designed to get teenagers to not smoke by never telling them not to smoke. And it's fascinating the kind of tools that these people use. Our example of this is a study that we did many years ago, and the picture of the iPhone, I really got to change that because it was pre-iPhone, so that turns out to be important for the story. This was a story where we were asking the question if a daily text message would improve adherence to sunscreen use. And we did this simply every day. We sent out a text message to one group and then another group not, and we measured their sunscreen use. We had a device that we could measure their sunscreen use. Now, what's interesting about the story is, and I wasn't involved with this, someone on the team came up with this, but they, at a time before smartphone apps, put the weather report in the message. And you see the results. The line on the top is adherence to sunscreen use, which is 60 or 70% in the group that got the messages. The bottom was control group, which decayed predictably over time. Great result. When we went back and asked the people, what was it about this? They said, well, we really didn't think much about sunscreen, but we enjoyed getting the weather report. That's what I mean about subliminal messaging. Also ties back to make it about life. These things are simple but really powerful. Unpredictable rewards. I don't have a healthcare example for this one. This is not new either. B.F. Skinner learned this when he was working with operant conditioning about a century ago or more. But and I know Uber's come up earlier today. Uber does this thing where when you open the app, every now and then you'll get a completely unrelated to ride sharing treat, a coupon or get a free ice cream or get a discount of something. And they do that because it's not their core business, but people open the app more just because they might see that. That's the power of unpredictable rewards. We can use that in our messaging too. Tactic number 3, again, is near and dear to my heart. This one ties back to social, the sentinel effect, and it's near and dear to my heart because as a clinician, this is a big part of what makes me effective, on all of us with our patients. Example, again, is Blood Pressure Connect. Also, we have an analog called Diabetes Connect, which is for diabetes. You can see the technology, again, pictured at the bottom right, There's the cuff, there's the glucometer, and then there's this hub device that extracts the data, moves it to the cloud where it's viewable. On the bottom left, you see a clinician looking at a dashboard of patients in the system. The software flags people who are out of parameter, and the clinician can reach into their life and have a conversation with them about why their data are out of parameter. And the gray bars show you the effects. In both blood pressure and diabetes, positive effects from these two interventions. When we go back and ask the patients, why were you particularly adherent to this intervention, they say two interesting things. One, they'll say, because someone from my doctor's office called and I knew they were watching the data. I wanted to be on my best game because my doctor was involved. And the second flip side is when the doctors or their nurses or diabetic educators, what have you, are not involved, the people just basically stop using the program. I'm not doing this for me. That's craziness. It's your life. But I'm not doing this for me. I'm doing it because my doctor's watching. Doesn't matter. It works. That's the sentinel effect, incredibly powerful, and we can leverage that as well. Now, what would it all look like, you might ask, if we pulled it all together? Well, the answer is I don't know. This is all fairly new thinking. And it's hard for me to look and pick up analogs, but I picked up a couple of ideas that I think might be useful in helping us imagine what this might look like. This is a picture of Facebook Home. This is an app that Facebook put out about a year ago. It kind of came and went. And the idea was, if you have a certain type of Android phone, you could download this app, and whenever you opened your phone, you would see your Facebook first. And then you would go to your email or your whatever else it was you went to open your phone for, weather report, etc. Imagine if your health plan, or maybe you're in an ACO, it could be a provider organization if they're caring for you, had the deal with you that you could use an app like this for a lower premium cost, that whenever you opened your phone, you would get a relevant healthcare message before you went to do whatever you were doing. And again, just for that, if you allowed us to do that, you'd get a lower premium cost. That sort of thing is, I think, imminent. Remember, Progressive Auto now puts a sensor on your car. If you drive according to what they see as safe driving, they'll give you a discounted premium. Technology will allow us to do this. You'll see this happen. The other example I like is Google Field Trip. Now, this ties back to Google Maps. It ties back to the GPS on your phone. And it's interesting, in a place like Boston, where I come from, it's a blast because there's so much history in Boston. So you turn this thing on, you're walking about, and if you walk by the Old North Church or Paul Revere's home or the Constitution, it buzzes or rings, and you pick up your phone, and you get a very nice précis that you can read about the historic site that you're walking by. Well, how would that apply to health? It would apply if because I'm going to know your mobile purchasing data very soon. So if I knew what you had for breakfast, and I knew that you hadn't walked much because you were in meetings all morning and you were headed into McDonald's for lunch, maybe I could message you about a safer, not a safer, but a fresher, less caloric alternative. You might or might not like that. That might be too invasive. But the idea of being location aware in healthcare is a part of this vision, I'm quite sure. So I do think we can make health addictive, and I think we need to make health addictive. We're not doing it right now. Thank you very much.
So, Doctor, great stuff and great content. You got at least one comment here. What do you think the definition of addictive is? In other words, how much interaction do you want that's really changing the ability to interact with the patient? I mean, addictive is sort of a hyperbolic example.
It is. It's a provocative term on purpose to get people's attention. What I'm really talking, though, about is the fact that, as I've said a couple of times, if you're going to look at something 100 times a day, I would really like to be able to just, in that path, get you a health message. This is why I like the Facebook example, because we knew kids were on Facebook, so we created the Facebook group. And it just happens to be where they are, and we start throwing health messages in there, and you can see the result.
So it's not so much that health becomes addictive, it's you find the addiction and place health interventions in the path
That's the
of
thought.
people who are...
Yeah, that's the thought.
Here's a couple of questions from yorn.com Transform. Did you collect any data on non-adherence? It sounds like you did. Lessons learned from non-adherence?
Well, if it means how are we going to get the couch potatoes off the couch, boy, that's the challenge that we're trying to work on right now. In other words, how do we get people who are so checked out that they don't even volunteer to be in a study? That's a frontier. Remember, everything anyone has talked about, I think, in the days before and tomorrow, will always be about someone who came in enough to volunteer for a study or be part of something. And there's a whole group of people there that are so disengaged that they don't even do that. I don't have a solution for them yet.
Does your data talk about finding people who are high risk for non-adherence and determining what their addictions are and trying to intervene? Say a couch potato maybe is really, really interested in certain kinds of comic book characters. Is there an app that will actually seek out that interest peak and try to intervene?
Yeah, that's the vision of where we're headed, is that I will know enough about John Hockenberry that I can be very, and we talked about, I've watched you for a day and a half now talk about when it's relevant, when it's not relevant. If I could make all that messaging super relevant and super personal, our theory is that you would then become more engaged. And we know that engagement drives outcomes.
How different, and you've worked with young people in asthma, it sounds like, or at least you have data on that. How are young people's orientation to social networking and technology in general possibly changing the way in which we can make the doctor experience more available outside of the traditional office? In other words, are young people more predisposed to these kinds of innovations?
Well, my youngest daughter's 20, and she's of the generation where they break up with their significant others via text message. So that tells you something, right? I think they're very predisposed. On the other hand, we shouldn't forget seniors. We've had a lot of good luck with seniors, more iPads than iPhones, but they're pretty plugged in as well. The whole populace is plugging in these days, and it's really allowing us to achieve this new way of delivering care that's time and place independent.
Have you thought about models that would make this conditional in some way, that it would be a condition of having a smartphone account or something? I mean, you talked a little bit about what Progressive Insurance does, but are there ways of making this more mandatory so that you have a bigger pool, that people would understand that this was the sentinel effect was something that was more global rather than something they've opted into?
Well, again, another theme that we've heard a couple times over the time we've been together is that we are a libertarian society, right? You have the right to make yourself sick if you want. We'll take care of you later. I think we're a long ways from that. What we can hope for, I think, in the near future is more the carrot, if you will, than the stick type of incentives. That, like I said, if you agree to participate in this program, we'll lower your premium. There probably will come a time when, if you don't agree, you'll have a higher premium. I don't think that's the first thing we'll do.
But if the premium model goes away, if that model goes away, how do you create an incentive for people to participate in these kinds of things? What other models? Because we've talked about people being in a completely retail experience in terms of their health care.
Yeah, we've seen, so there's some innovations that we've seen come to us. For instance, there's one company that's looking at a plan where they'll offer people a free smart device in exchange for sharing their adherence data. And the more adherent they are, the lower their bill goes. It's a sliding scale. So people are starting to experiment with things like that.
You could definitely do some monitoring of behavior in like Vegas.
Well, you know, it is true that in connected health, one thing that I want to emphasize is, with all kidding aside, is that the interventions all have measurement built into them, because you're monitoring something, or you're opening a message, or you're engaging with an app. And as I said, engagement improves outcomes, and we now have a way to monitor and segment populations that we've really never seen before.
Did you see patients before your current sort of job and responsibility?
I did, and I still do.
You still do?
Yeah.
How has your patient experience changed because of some of this work that you've done?
I'm much more cognizant of listening to what's going on in a patient's life vis-a-vis telling them a straight, sort of out of a handout, if you will, what to do. With much more of a customized dialogue about how to get what they need to get done with their condition as a context of their life. And I mean, I take email from everyone, so I'm as electronic with them as we possibly can be.
But that's an interesting point, and let's just explore it for a moment. And I have one question from online to give you before we move on. You know, we talk about this kind of humanizing, relationship-driven healthcare model that we want to get back to, or we want to make sure we don't forget. And we often talk about it in purely sentimental terms that don't deal with people like numbers, deal with them as humans, and we have a sort of intrinsic, intuitive sense that that's valuable. But you're saying something different. You're saying that, in fact, that relationship is really an enabler of doing your job. That
Well, or
it's not
improving
just a
outcomes.
thing. Right?
Yeah, it's a medical thing. It's not just a sentimental thing.
Good messages, one person writes. What would you have done differently? Did you try any cohorts with multiple comorbidities? I have no idea. You know, I've heard that a lot. What are multiple?
Comorbidities means you have diabetes, high blood pressure, and depression all at once. Those are three things. That's what that means. We haven't done that yet. As anyone in the audience knows who tries to study these things and have data to report, it's best to start with a clean sample that's got as few variables as possible. So in the real world, we study people with comorbidities, but we don't typically have the sort of clean data sets that we have when we separate people out.
So the translation of this is, did you try any experiments with people who have a number of problems?
Yes.
Yeah.
And the answer is a lot of these programs are now in the real world in our delivery system being implemented, and we're learning about that, but not in the kind of p-value way that you can report out as a paper or as a bar graph or what have you.
Who came up with the word comorbidities?
I don't know that one.
Boy, yeah. It's a strange word. It's a scary word. It gives me the creeps.
At least I didn't.
I've heard it
You
for
can't
years.
blame me for that one.
Yeah. Anyway, that's a cheap shot. But doctor, thank you so much.
Pleasure.
Yeah.